Good day, everyone. My name is Oketope, and today I'll be presenting my research on how religion affects maternal health care access in Nigeria. Maternal health is not just a medical issue, it is deeply shaped by culture, economics, and especially faith. My study combines secondary data, literature review, and qualitative insights from a healthcare worker to understand this relationship and propose policies for improvement. Nigeria accounts for about 20% of maternal deaths worldwide. But this is staggering and makes maternal health one of the most urgent health issues facing our country, my country. At this same time, Nigeria is religiously diverse. Roughly half of the population identifies as Muslim and half as Christian, with smaller groups practicing traditional religions or identifying with none. Religion shapes trust, family decision making, attitudes towards medical procedures, and even whether women deliver in hospitals or prayer houses. This raises the central question of my research: how does religion influence maternal health care access in Nigeria? To answer this, I used 1. Quantitative data from the Nigeria DHS and UNICEF MICS survey. This include variables such as religion, place of delivery, antenatal care, attendance, number of prenatal visits, and health insurance coverage. 2. I used literature review across studies from Zamfara, North Central, Southwest, Adamawa, and comparative research from Zambia and Kenya. 3. I used qualitative interviews, including one with a healthcare worker who has over 20 years' experience in maternal health. This mixed approach allowed me to capture both the statistics and the lived realities of Nigeria women. Key findings. My findings reveal strong disparities. 1. In the antenatal care, Christian women averaged about 8 visits compared to 7 for Muslim women and 6 or fewer for traditional or non-religious groups. 2. In place of delivery, Christians had far higher facility delivery rates, around 11,970 cases compared to 4,250 among Muslims. Smaller groups showed even lower usage. Insurance coverage. Very low overall women remain uncovered, limiting across regardless of religion. But numbers alone don't tell the whole story. From Zamfara State, a Muslim-dominated region, studies show that modesty norms and male dominance discourage hospital delivery. In the Southwest, where educational levels are higher and religious mix is more balanced, uptake of care is higher, but many still prefer traditional birth attendants for cultural familiarity. The healthcare worker I interviewed shares stories that illustrate this vividly. She explained that many women, both Christians and Muslims, resist cesarean sections because they are seen as not the normal way to give birth. In one case, the woman refused surgery despite complications and chose prayer instead, only being rushed to the hospital when her condition worsened. She also described women refusing male doctors even during emergencies due to modesty. In one extreme case, a woman in labor closed her legs when the baby's head was crowning, and the doctor had to physically intervene. Finally, she emphasized that husbands and faith leaders play critical roles. Women often follow their pastors or imams' advice over medical advice. Male partners frequently decide whether women can attend clinics at all. Discussions. These findings highlight that religion is both a barrier and a support. On one hand, faith-based beliefs delay or prevent women from seeking care, particularly regarding cesarean sections, male doctors, and prayer house deliveries. This is especially pronounced in Zamfara and other northern states. On the other hand, religion also provides emotional strength and stress. When pastors and imams endorse healthcare, women are more likely to comply. In the Southwest, higher literacy and interfaith engagement make it easier for women to balance faith with medical care. The bigger picture is that religion interacts with education, gender roles, and poverty. Where education is higher, women are more empowered to seek care, even when faith discourages it. Where poverty and weak systems prevail, religion fills the gap, but sometimes with harmful consequences. Policy recommendations. To address these issues, I propose several strategies grouped into 3 themes. 1. Facility level reforms. And under it is one, to integrate prayer spaces in hospitals so women feel spiritually comfortable, and two, train healthcare providers in cultural sensitivity. Under community engagement, I propose that hospitals should partner with pastors, imams, and traditional birth attendants to promote safe delivery. They should also launch male education programs teaching husbands about medical ethics using role play simulations with dummy pregnancy models. 3. Systemic financing and outreach. Expand insurance coverage for maternal care, strengthen referral and emergency transport, and deploy NYSC members, the National Youth Service Corps members, to rural areas to spread awareness and provide basic support. These combined approaches respect culture and religion while improving health outcomes. In conclusion, religion is not just a background factor, it is a central dominant of maternal healthcare access in Nigeria. By engaging faith leaders, empowering women, educating men, and making hospitals more culturally attuned, we can save countless mothers' lives. My research shows that solutions must be both medical and cultural. Only by working with religion, not against it, can Nigeria move closer to achieving the Sustainable Development Goals on maternal health. Thank you. I would also like to thank my mentor, Miss Sarah Hussein, whose guidance and support were invaluable throughout this project. Thank you so much.